the slides of my, my disclosure slides, and then I've got separate slides to present. So briefly, just to mention financial interests, I have grant support from different groups currently, either as lead investigator, co-investigator, no speakers bureau or honoraria, no consulting fees in the last 2 years, no patrons. That sounds like a nice idea, but so far none. And yeah, I'm a faculty expert as part of the, I teach online as part of the Canadian Academy of Geriatric Psychiatry's Geriatric Psychiatry online course on suicide prevention. So much of the same information. And I note that the program's not received financial support other than from RBC Foundation, no in-kind support. And in terms of conflicts or potential ones, I've collaborated with colleagues at Baycrest and at the Canadian Coalition for Seniors Mental Health for many years, and have presented at the CAGP meeting. And that's it. Try and focus as much as it's possible on evidence-based care, and the information is peer-reviewed. And I think that's it for that. So let me now switch over to the, I will stop. So to start with, so as you know, the topic suicide prevention in older adults. I'm always happy to chat with colleagues. Email is the best way these days. And just to acknowledge again, funding support from various groups for some of the information I'll be presenting, as well my colleagues, research assistants, students who have participated, and of course, all of my clients, research participants, and community members. So in terms—
Marnin, I don't think we can actually see your slides at the moment for some reason.
Oh, it says my screen share is paused. Let me stop.
Yeah.
Okay, excellent. Thank you. Yeah, and please let me know if there are any challenges like that. So the main objectives to share some information on epidemiology, risk and resiliency factors for late life suicide, to share a humanistic perspective on working with older adults at risk for suicide, and tell you a little bit about some of the knowledge translation tools that we developed some years ago through the Canadian Coalition for Seniors Mental Health. So to start with, why don't we move to a few multiple choice questions? And I believe, oh, perfect, there we go. So according to the WHO, approximately how many people of all ages die by suicide every year around the world? I will close my poll because you probably don't need me to answer it. And okay, there we go. So we see, okay, nearly evenly split between 45,000 and 800,000. The answer is actually 800,000. The 45,000 is close to the number of people lost in the US every year, 4,000 roughly the number lost in Canada, 600 roughly the number of older adults lost by suicide in Canada every year. On to the next one. Which of the following factors carries the highest risk for death by suicide in later life? Depression, previous suicide behavior or attempts, misuse of alcohol or other substances, or social isolation? And I think we can agree that they all certainly contribute or can contribute. And we see that the highest response is actually social isolation, which is interesting. I think these days, especially given COVID, we're all very sensitized to the issue. And of course, social isolation can certainly contribute to obviously feelings of loneliness, depression, hopelessness, and thoughts of suicide in older adults. But in reality, previous suicide behavior is the factor that is most highly associated with risk for death by suicide. And when you think about it, often the best predictor of future behavior is past behavior. So whereas these all can contribute, it's really the previous suicide behavior we're looking for. On to the next. Having which of these increases risk for suicide? Functional limitation, cognitive or memory disorder, mental disorder, or terminal illness? And again, certainly you might think of individual cases where any or all might contribute, but we are looking for the best answer in this case. Yep, we got it that time. 57% said mental disorder. And in fact, with some of the others, there isn't strong evidence supporting independent associations. And one thing, we'll come back to terminal illness in a moment, but there's been a long belief that older adults with terminal illnesses are at increased risk for suicide, and it's not necessarily the case. So two more. Which of the following is true regarding late life suicide risk? Take any threat of suicide or wish to die seriously. Once a person's suicidal, they'll have suicide ideation for the rest of their life. Risk is low when someone starts emerging from a depressive episode, or asking about suicide essentially can make somebody suicidal, plant the idea in their mind. Absolutely. 97% said take any threat of suicide or wish to die seriously. No need for discussion on that point. And finally, research evidence supports which of the following in reducing suicide risk among older adults: collaborative care between mental health providers and primary care providers, psychotherapy and medication, community outreach, social support, all of the above, or none of the above. I think none of the above we can probably take right off the table. And I think we've probably seen enough of these to know all of the above. Hey, 100% there. You don't need me. I can go now. Fantastic. Absolutely. Okay. So this, just to sort of reset, this comes from the International Association for Suicide Prevention that uses this poster every year on September 10th for their World Suicide Prevention Day, to remind us that with roughly 800,000 deaths by suicide every year, that can be seen to translate to a death every 40 seconds or so, which means that people are bereaved by suicide every minute. So yes, the WHO says about 800,000 lives are lost every year, or roughly 2% of all fatalities for all causes worldwide, which exceeds the number of lives lost to war and homicide combined. So when you think about it, we're a particularly aggressive species, and we kill each other far too often, but we kill ourselves more often. These costs are staggering. So one group called Parachute estimated it as nearly $3 billion a year in Canada. This was some years ago, or more than 10% of all injury in Canada. But of course, the true cost of suicide is in lives lost, which you can't put a value on. In Canada in 2019, so these are the latest data from StatsCan. I actually just updated them yesterday. Just over 4,000 people died by suicide in 2019, including over 3,000 men or boys and nearly 1,000 women or girls. So in fact, we see that men and boys account for about 3/4, in this case, just over 3/4 of deaths by suicide, which corresponds to a national rate of about 11 per 100,000. And again, comparing men and women, we see roughly a 3-to-1 difference in the rate of suicide. Now, older adults, and a lot of people don't know this, I'm sure many on the call do, older adults and older men in particular have highest suicide rates in Canada, the US, and most countries worldwide. And again, this is from StatsCan for 2019. The dark blue line at the top are suicide rates for males across the life course, the turquoise line at the bottom for females, and the purple line, both the wavy line here, the graph in the middle, and then the flat line represent, shouldn't have said flat, anyway, represent the overall suicide rate. So we see 10.7 per 100,000 doesn't do a great job of representing or reflecting the variability, but we see almost no deaths before adolescence, in part for legal reasons. Children are believed to not be able to form legal intent, and therefore even those who kill themselves, and some tragically do, aren't classified as deaths by suicide. So we see this tremendous jump for early years, early adulthood. The main mode or most frequent deaths overall tend to be in midlife for men and for women, and overall we see a reduction in deaths by suicide into early older adulthood. And then for men, for women, the secondary curve doesn't always appear. Some years it does, some years it just continues to drop. For men beyond age, in Canada, more like mid-70s, in the US, mid-60s, increases dramatically. And we see 2019, as in many previous years, men in their mid-80s, mid to late 80s have the highest rates of suicide in the country. Now, this is especially concerning to all of us working with older adults, but especially recognizing that the global older adult population is expanding. As many as 1/5 to 1/4 of North Americans will be over 65 by 2030. In the US alone, that can be over 50 million people. And generally speaking, according to the WHO, people are living longer and are not succumbing to infectious disease. Of course, over the past year, they have been. And so it certainly makes me wonder about how COVID and especially loss of older adults will impact population demographics going forward. But needless to say, this is what we anticipate, a tremendous growth in the older adult population in Canada over the next number of decades. And when we think about the fact that older adults have high risk of suicide and the number is increasing, some have described it as sort of a perfect storm for late life suicide. As we see, just under 10,000 North Americans over 65 die by suicide every year. And the other thing to recognize is that these numbers are increasing. So over a roughly 20-year period, the number of individuals who died by suicide in Canada have increased by about 11%. But when you focus on those over 65, it's more like a 60% increase. So older adults have had an increase in suicide rates that far exceeds the rest of the population. In part, older adults often use highly lethal means of suicide. This is especially the case for men, and part of it does have to do with the manner in which coroners determine or classify cause of death. So with older adults being more likely to die by all causes, it tends to be the much more obvious suicide deaths that come to their attention as such. And various coroners have said over the years, the true number of older adults who die by suicide could be 50% higher than official statistics, maybe even double. But when we look at firearm use in particular, it's one of the commonest means used for suicide among older men. And here we just see the raw numbers. Previously, I showed you the rates per 100,000, and you can see from 2000 up to 2019, slight increase. If we focused on older adults and exclusively, you'd see a much sharper increase. Now, the good news, suicide is preventable. And in suicide prevention, we use, so overall by prevention, I mean preventing people from dying. However, we use specific terminology in suicidology, the study of suicide and its prevention, where prevention refers to a period of time before people are at risk or are at imminent risk. So we might think of this as sort of upstream or early prevention when people are not yet in need of or receiving mental health care. And so any initiatives at this point are to keep people from becoming suicidal. Move along time-wise, intervention, we might think of mental health intervention, crisis intervention, is what we provide when people are at risk, when they're struggling with depression, hopelessness, loneliness, loss, etc. And then postvention is a term that was originally coined for the supportive services we provide for people after a death by suicide, community outreach, bereavement support, etc. More recently, it's also been used to describe care provided for people after they've tried to kill themselves and survived. And the reason for this arrow is to show that good postvention becomes good prevention, because people who have engaged in suicidal behavior or lost someone to suicide themselves might be at elevated risk. So what works? If I say suicide is preventable, what does the literature tell us? Well, I'll very briefly touch on two large multinational literature reviews. The first headed up by John Mann at Columbia University in New York and colleagues worldwide, looking at a roughly 40-year period, over 5,000 articles looking at suicide thoughts, behavior, and deaths as outcome. And they found support for educational training, general public and healthcare providers, screening, interventions, both medication, psychotherapy, follow-up care, restricting access to suicide means, like putting up bridges on bridge barriers on hotspots, reducing access to carbon monoxide, gun control, alcohol control, etc., and working with the media so that their presentations on suicide are less likely to induce a contagion effect. About a decade later, I'm going in the wrong direction now. What happens when you use a touch screen? Gil Zaltzman and colleagues, Zaltzman is in Israel, he and colleagues, many of the same people who had done the original review, updated it, another 1,800 articles, still strong support for restricting access to means, increasing awareness and education, psychotherapy and pharmacological intervention, with less support for screening and media guidelines and more research needed for these other areas. So I will say in terms of training, we know that many older adults who are at risk for suicide never make it to see a mental health provider. They're likelier to go to an emergency department or their family provider. And in fact, although I'm showing data from 2002, going back 50 years, we've got evidence suggesting that nearly 75% of older adults who die by suicide had seen their doctor or other healthcare provider in the previous month. But even when older adults do access mental health services, they often don't receive recommended care due to a lack of information commonly among healthcare providers, mental health providers about suicide prevention approaches with older adults. And of course, educational training can help, which is one of the reasons for having sessions like this. So as many of you know, in 2005, the Canadian Coalition for Seniors Mental Health received Public Health Agency funding to develop a set of 4 guidelines focusing on seniors' mental health, looking at delirium care, depression care, assessment and treatment of mental health issues and long-term care, and in suicide assessment and prevention. And I was involved in helping with those latter guidelines. And you see this is what they look like. Now, I will say these are still available online on the Canadian Coalition for Seniors Mental Health website. It's time from 2006 until now, it's time for us to update them. And we're talking about hoping to do that, and certainly would appreciate input and assistance from others in doing that. You see here what the guidelines focus on, many of the things we're touching on today, and they've been widely disseminated, both hard copies and online copies, and we've since developed other tools. Here you'll see a clinician pocket card for providers, training DVD, a facilitator's guide so that people can teach their own colleagues about it, as well as a guide for family member. And we even received some funding from CIHR to do a dissemination and evaluation of dissemination, where we offered half-day workshops to providers on using those tools. We assessed change in knowledge and attitudes towards working with suicidal older adults and found a significant improvement in knowledge in the topic and a shift in attitude towards especially feeling more competent in providing care. And clearly more work is needed. But just also to acknowledge that other guidelines do exist, including at the University of Iowa, where they updated their guidelines from some years earlier. Now, I'll touch very briefly on suicide risk assessment, intervention, and aftercare. So to say that as a cohort, and of course I suspect this to be changing as more baby boomers are reaching their later years, but generally speaking, depressed and suicidal older adults have a tendency to downplay negative psychological symptoms. They don't want to burden others. They feel uncomfortable sharing this information. Nevertheless, we have to ask the question, we have to assess for thoughts of suicide. And of course, we need to do that in a sensitive, humanistic, and appropriate manner. Often use of collateral source information can be very helpful. And again, to the notion of taking a humanistic approach, suicide risk assessment, as with really all clinical assessment, is ideally carried out in a sensitive fashion in the context of a trusting therapeutic relationship, where especially when somebody is being asked to share information that's very sensitive, very personal, that they might be extremely embarrassed about, and recognize that if they openly share thoughts of wanting to kill themselves and how they might do it, they might end up hospitalized and at least temporarily losing their freedom. So we've got to be very sensitive to that. 4 main approaches that are used for suicide risk detection, focusing on assessing suicide risk factors, which generally comes from aggregate data from large population level studies and may or may not apply to the individual, but certainly should guide our practice, as well as focusing on the flip side, protective factors or resiliency factors that decrease the likelihood of thinking of suicide or that contribute psychological strength, the ability to bounce back. We might use standardized assessment tools or interviews or focus on warning signs. And these are from the Coalition Toolkit. Among the risk factors, we acknowledge Having suicide thoughts and behavior currently and lifetime can increase risk. Having a family history of mental health issues and of suicide can increase risk. Having a mental disorder, certainly we think of mood disorders, depression, bipolar disorder, but certainly anxiety can increase risk, somatization, psychotic disorders, and substance misuse. Certainly personality characteristics and personality disorders can increase risk. And again, if we think of all of these things together, or the more comorbid conditions, the greater the risk tends to be. Medical illness and certainly experiences of pain can increase risk. Negative life events and transitions are really, I think of it as the bread and butter of the work that we do in mental health care. Those tend to be the issues that bring people into our offices or emergency departments or clinics. This is where we live, in our relationships, in our work, in our psychosocial issues, and fear of loss of those or change of those. And certainly functional impairment can increase risk. A quick word on terminal illness. I've mentioned this before. Suicide in late life is commonly about emotional pain, including depression and other psychological difficulties, and not typically about terminal illness. A colleague at the Boston VA conducted a retrospective analysis some years ago, finding that 30 to 40% of older adults in the States who died by suicide were medically ill, but very few, 2 to 3%, were terminally ill. And it's true to say, and fair to say, I think, that most suicidal older adults are not terminally ill, and most terminally ill older adults are not suicidal, but some are. So it's important to detect and assess for suicide risks in individuals, especially around the time that they're given a negative prognosis, terminal prognosis, because that can quickly lead to thoughts of suicide. For many, those thoughts disappear fairly quickly. For some, they don't. And of course, things have changed over the last 5 years with legalization of medical assistance in dying. And of course, we expect that that might change more in coming years, especially as those with mental disorders alone will be able to access MAID. And this is just to show people, if you're not aware, that the average age of Canadians who have accessed MAID is about 73. There's actually an equal division of men and women, suggesting that when men want to end their lives, they're more likely to use highly lethal and violent means, including firearms. With women, they might be more likely to turn to a medical provider. And in fact, you can see in the notes here, of those who died using MAID, at least in this year, 2017, 99.95% elected to have a clinician do it, so euthanasia, rather than do it themselves. In terms of resiliency factors, pardon me for a second, we see some factors that could increase resiliency or psychological well-being and decrease risk for suicide, including spirituality, sense of meaning and purpose in life, which is where I've done a lot of my work, especially intervention work, trying to boost a sense of meaning in life, optimism, social support, etc. And colleagues and I have developed this conceptual framework. We know that risk factors, depression, loss, negative experiences, biopsychosocial factors can increase thoughts of suicide directly or by way of losses and negative transitions, which can, if they aren't alleviated and other factors present, lead to suicide attempts and death. But that psychological resiliency factors, meaning in life, well-being, social support, can potentially decrease risk. And we note also that we can intervene at various steps along the trajectory. Before risk is apparent, during times of life transition and loss, when people are struggling with depression and suicide risk, and even after the behavior or death. So again, risk assessments have to be carried out sensitively. Rating scales and other measures can be helpful, but they aren't the intervention in and of themselves. You're the one who carries out the intervention and can consider the feedback and the input that you get from rating scales and interview measures, together with clinical interviews, assessing family members, etc. With any scales, be very aware of validation issues. Don't necessarily take them at face value. Sometimes, again, people who are suicidal will deny it for a variety of reasons. If you're going to use scales, do so within your competencies, recognizing that there is no one best tool out there, but that they are really geared to particular situations, cohorts, and providers administering them. I will say that tools are best used that have been designed and validated for a specific population. My colleague Gord Flett and I some years ago developed what at the time was the first scale really to look at suicide ideation as well as resiliency that we call the Geriatric Suicide Ideation Scale, which although the acronym is GSIS, we say does not spell Jesus. Many people think it does, but it doesn't. It's the GSIS. And more recently, we have developed an abbreviated 5-item screen that we call the GSIS screen. And for those interested, by all means, reach out to me. I'm happy to share those with you. And to note that other scales have also been developed. In terms of assessment, you can see from the coalition, we note a process for assessing risk, respecting the dignity of older adults, giving them the opportunity to share their experiences, tell you in their own words what they're going through, and to validate their feelings. We should also assess for resiliency, and as I mentioned, look at collateral information, always being aware of ambivalence, which in this case, we're not talking about necessarily unconscious versus conscious wishes, but ever present in most people who are suicidal. Together, our wishes, together with the wish to die, is a wish to live. And I've often thought of it sort of as a balance beam or a seesaw or teeter-totter that kids are on that can go one way or the other. And we want to try and push down on the wish to live and alleviate the wish to die. We do that by asking about feelings, plans, and reasons for living. In terms of interventions, we can intervene at the population level. So population health interventions are considered universal. Things like fluoride in the water supply to prevent tooth decay. Selected interventions are for groups at elevated risk, like older adults or older men, and indicated for individuals at imminent risk. And clearly interventions are needed or programs at all levels, as well as at public health, community, and clinical levels. And I'll just say one for each. Public health level intervention to prevent suicide can include, as we've mentioned, means restriction like gun control, clinician education. Community initiatives can be gatekeeper training, or DeLeo and all had looked at outreach telephone support. Oyama in Japan also looked at community lectures on depression, screening for depression, and outreach psychosocial support for depressed older adults that actually led to a reduction in the suicide rates, and clinically, again, psychotherapy, medication, and aftercare. Here we see some medical interventions that have been linked to reducing risk for suicide, albeit not in studies specific to older adults. And with psychotherapy, 15 years ago, there was very little. There's some more now. I know I should probably speed up and get done within a minute or so. But I will say that there is support for problem-solving therapy and growing support for other cognitive interventions, for interpersonal psychotherapy, and for meaning-centered approaches. And clearly, in addition to having a trusting, genuine relationship with older adults, we should try and foster hope in them, help them to explore areas in which they can still find meaning in life, even if they've experienced losses. Risk management, you'll be able to review these. Clearly, don't leave someone alone at imminent risk. Develop a safety plan, consider their multidimensional care needs, address underlying issues, assess risk on an ongoing basis, and foster hope. So what should we do in the last moment? We have to be willing and interested in learning about who our clients are as human beings. Sit and listen to them non-judgmentally. Be interested, supportive, and approachable. Find out about what's going on and what they anticipate to happen in the future. Don't assume all is well. Question, but always listen for that little voice in the back of your head or the hairs on the back of your neck or your gut, and make sure to involve others. Obviously, keep notes. Documentation is critical. Don't use so-called no-harm contracts. You can't kill yourself before we see each other again, or I won't care for you anymore. All that does is apply pressure to somebody and might actually drive their open disclosure of suicidal thoughts underground. Plus, you could put yourself in a bad legal position by doing it. Instead, focus on building safety plans for what to do when somebody does feel suicidal again, which can include reaching out to you or other healthcare providers, or pleasant activities for lower risk. So ultimately, suicide is a human problem, and it necessitates a human response. There's no one individual approach to preventing suicide, and so we've got to be creative, We should know the evidence, but be willing to tailor it to the individual sitting in front of us. Ed Schneidman, who was a clinical psychologist at UCLA, who came up with the terms suicidology and thanatology and really started this field, came up with a term called psychache or emotional pain, which he felt drove thoughts of suicide. A colleague in Windsor, Anton Lenar, similarly said that suicide results from psychological pain. And so anything we can do, anything at all, to alleviate psychological pain of our clients should start reducing risk. So know where people hurt, know what causes pain, and find ways of working collaboratively with them to reduce it, as we note here. So ultimately, we can't predict who will die by suicide, but we can assess risk. Outreach is critical, as is assessment of risk, assess access to lethal means, history of behavior, be open to discussions of suicide, and communicate with your colleagues. Because as we say in the field, suicide prevention is everybody's business. We each have a role to play, which will differ depending on our experience, our training, and the role that we have at that moment. And we should be aware of that, what that is, know the other resources available, and know before we sit down with somebody who's suicidal, what plans we might use if we encounter somebody at imminent risk. So I think I will stop at that point and just